further delay, so I'd like to share with you again the data of acute stroke treatment. So the most effective treatment on top of this pyramid, pyramid will be a mechanical thrombectomy. So the number need to treat is just 3 to 7.5. So this number need to treat is even lower as compared to PCI in myocardial infarctions. So as you know that recently ever seen the publication of Mr. Clean data subsequently have been shown that mechanical thrombectomy is very effective. Then second, followed by the evidence for mechanical thrombectomy, then you will be RTPA or thrombolysis with IV alteplase. The number need to treat is 8 to 14. And number 3 will be stroke unit. So by putting all the stroke patients together with the organization of stroke unit, you also achieve a better improvement into of the stroke patient outcome. So the number need to treat is 28. Various the antiplatelets such as aspirin or clopidogrel, the number need to treat is 111. So you need to treat one patient to make one patient better in terms of the stroke recovery. So again, I like to highlight the reperfusion therapy, which is mechanical thrombectomy and IV alteplase, is the most effective treatment in terms of acute stroke treatments. So number 1 will be IV alteplase, number 2 will be mechanical thrombectomy. So my talk today will be focused on how we select the patient for reperfusion therapy, particular how do you select the patient for IV alteplase. So with the recent data within these 2 years, getting more and more data, we show that actually IV alteplase is getting could be used to, probably we can use IV alteplase to replace IV alteplase because IV alteplase is cheaper and it can be given by bolus because IV alteplase can be only given by infusions. So hopefully by a few years or few months, we can confirm by getting more and more guideline and more paper published to confirm that IV alteplase can replace or can be used an alternative as compared to IV alteplase. So I will start with the case number 1, Madden Chong, 72 years old, right hemiparesis with a stroke onset of 2 hours. So as you know, the benefit of RTPA or thrombolysis is time dependent. There are so many data from MINS trial, ICAS-3 study have been confirmed. Less than 4.5 hours is the golden window period for a patient to receive a thrombolysis treatment. So this is one of the very important absolute contraindication if you work in the stroke ready hospital. Once the patient onset is more than 4.5 hours, then probably you are not considered the patient for thrombolysis. So this is a meta-analysis published by Dr. Amberso in Lancet 2014 with a combination pool cohort of so many RCT that confirm less than 3 hours if the patient presented to the hospital, there are 75% of the chance with the odds ratio of 1.75 they get better in terms of stroke recovery if the patient receives thrombolysis treatment. If the patient presented to the hospital 3 to 4.5 hours, then they receive the thrombolysis treatment, they have the 26% of chance to get improved with the odds ratio of 1.26. If the patient presented with more than 4.5 hours, then the odds ratio is 1.15 only. So the benefit of RTPA is time dependent. So the risk of bleeding is higher when the patient presented to the hospital more than 4.5 hours. So this paper also highlight actually age shouldn't be the absolute contraindication for patient. It also show that if the patient more than 80 years old, there could be benefit from RTPA. If the NIHS score is more than 16 or 22, there's still benefit on NIHS score. So those age or NIHS more than 16 or more than 22 shouldn't be an absolute contraindication for RTPA treatment. So again, this table highlight the benefit of those RTPA is time dependence, and the benefit is similar regardless the patient's age and stroke severity. So again, how do we treat a stroke patient? This should be a 4-step. You should go through one by one. How do you make a treatment, start the treatment of stroke thrombolysis in the acute ischemic stroke patient. Number one, of course, we like to confirm the diagnosis, this is ischemic stroke, and at the same time, we try to rule out all those stroke mimic patients. Number two, we will check the CT scan and exclude bleeding. Bleeding is a no-no for thrombolysis. So you have to know how to confirm there's an intracranial bleed or there's a hemorrhagic stroke in the patient. Then we cannot exclude the patient. We should exclude the patient for thrombolysis. Number three, we can assess the patient of the stroke severity by seeing the CT scan, by compare the clinical presentation, by doing an NIHS score. Then we give us an idea whether the CT scan, whether the patient have more than 1/3 of MCA infarct. Let's say to confirm this is a fully established infarct, MCA infarct, then the risk of bleeding is very high. The risk of reperfusion injury is very high in this group of patients. From that, we will exclude the patient. If the patient confirmed ischemic stroke, if the patient has no bleeding, if the stroke severity or from the CT scan is less than 1/3 of MCA infarct, then we'll run through the checklist to make sure the patient have no contraindication. Then we can start the patient on RTPA or IV alteplase. So how do we confirm diagnosis of ischemic stroke? Again, from the history of ischemic stroke, according to the stroke presentation, right hemiparesis, left hemiparesis, then the onset is very important because more than 4.5 hours, and most likely we can't put the patient for RTPA or thrombolysis treatments. Again, you take a short history, and the most important piece of history in the stroke is the time of onset. So we can ask the family member, we can ask the witness, when is the last time the patient unable to talk, unable to walk, something like that. Then we can ask if the patient presented with you with a wake-up stroke. Then we can ask the patient when is the patient is last seen well. For example, if the patient presented to the hospital in the 8 a.m., then we ask the patient or ask the family member, when is the last time the patient was well? For example, the patient walked to the toilet around 3 a.m., then we take the 3 a.m. as the last seen well time. So we can create a question to determine the time of onset, something like when was the patient watching a TV program, when is the patient, or we check the mobile phone record and the patient routine, like the patient is just took a taxi with a taxi receipt, etc., etc. Of course, again, you can ask the caretaker, you can ask the witness, and if the patient has no aphasia or dysphasia, then you can ask the patient. So in the clinical diagnosis, the examination should include, we check the vital sign, particular blood pressure. If the blood pressure is more than 185 over 110, then we cannot put the patient for RTPA. We have to lower down the BP. And of course, we have the history. Apart from symptom, the most important piece of the history is the onset. And we do a quick NIHS. Then we check for the contraindication, then evaluate significant lab result whether the patient has any contraindication, a quick one. So those are the causes for stroke mimic. There are many causes. So for example, alcohol intoxication, cerebral infection, metabolic disorder, neuropathy, something like Bell palsy, presented with lower motor neuron or facial nerve palsy, brain tumor, migraine, seizure, and post-seizure state like something like thought paralysis, hypoglycemia, epidural hematoma, drug overdose, toxicity, and hypertensive encephalopathy. So there are many causes the patient may present something like a stroke, what we call a stroke mimics. So for your history, you can get, sometimes you feel like something is not right, then you can get a further history to confirm that whether the patient has stroke mimic. For example, a metabolic disorder like hypokalemia, patient presented with weakness, then you just double confirm whether this is a stroke mimic or not. So before you proceed with thrombolysis. So of course, hypoglycemia also can cause some focal neurological deficit. So make sure you check the glucometer or dextrostate, make sure this is not a hypoglycemia. Let's say it's hypoglycemia, then you correct the hypoglycemia, then you double confirm that whether the patient have a concurrent hypoglycemia and acute onset of ischemic stroke. So number two, we should exclude bleeding. How do we exclude bleeding? Just by doing a CT scan is sufficient enough because CT scan is one of the very sensitive investigating tool to confirm whether the patient suffer from intracranial hemorrhage or hemorrhagic stroke. So by point here, then you give you some HU or Hounsfield unit. Let's say you a bit confused with the calcification in the brain, then you click. Most of the time, the calcification will give you a ranging more than 70, but blood, they will never give you a HU more than 70 or Hounsfield unit more than 70. It should be around 60 to 70. Then you point that, you give you a reading, then you confirm this is bleeding. Then you point here, then 200 plus, 100 plus. Then you know that those are calcification of the choroidal plexus. Then you shouldn't confuse with these two. Then you know that this is bleeding. Then immediately you can exclude the patient or rule out the patient for thrombolysis. So there are something that imaging way that you can help you better. Of course, if your center have MRI, definitely MRI is a better imaging for posterior circulation stroke, like cerebellum stroke or brainstem stroke. But sometimes that with the facility of CT scan will be enough for us to start a stroke-ready hospital service to start any thrombolysis. So we can assess the severity, something like we can use the aspect score. We can measure, you see that the MCA territory is not more than 1/3. Of course, you can compare the patient whether the patient had a very bad NIHS score or not. So I will touch a little bit on the aspect score. So like as I told you, the acute stroke severity, then you can check whether like something like this CT scan, which is more than 1/3 of the MCA. Definitely you have to rule out this patient for thrombolysis because the risk of reperfusion injury is very, very high. So another way probably we can consider is aspect score. So what is aspect score? So basically aspect score is a range of score that more is total of 10. Let's say you have an aspect score of 10. You show that this is a normal CT scan. Let's say the patient aspect score is 0. So it means that there is a diffuse ischemic damage. So aspect score divide the MCA region to the 10. So the middle cerebral artery to the 10 region. So at the level of basal ganglia, there are 7 regions. So the C is stand for head of cardiac nucleus. IC is stand for internal capsule, which is here. L is stand for lentiform nucleus, which is here. So the cortical area of the basal ganglia is divided to M1, M2, and M3. So just one level above basal ganglia will be M4, M5, and M6. So there are 7 at the basal ganglia level. We plus another 3 just above the basal ganglia with a total of 10. So aspect score, once you see any hypodensity over this area, then the patient will get a -1 for aspect score. So every patient will start with the aspect score of 10. So when you read through the CT scan, you check whether there's a hypodensity over here, then be -1, -1, -1, -1. So if the aspect score is more than 7, it means that there's very minimum fully established infarct, then the patient may benefit from reperfusion therapy. If the aspect score is less than 5, so most likely patient is unlikely benefit from treatment, and the patient may have a higher risk of bleeding. So this gives you some idea that if the aspect score is very low, then you would like to double check again and confirm with the clinical examination whether the NIHS score is very high, then confirm the patient already had a very established stroke. So this is the NIHS score. There are 11 items under NIHS score. So you can go through. The score will be 0 to 42. So I'm not going through very detailed for that. So you can Google, you can watch in a few websites, in the YouTube. There are some free online video tutorial from that. And there are some exam, online exam, which is free. You can get a free certificate for NIHS. So number 4, we should check for those identified contraindications. So those are the indication for thrombolysis. Actually follow a broad category. There's something like increased risk of bleeding, the stroke severity, unstable patient, the age of the patient, but this is not an absolute contraindication. This is something like relative. As I told you before, from the paper or meta-analysis, age more than 80 shouldn't be an absolute contraindication. and the stroke onset more than 4.5. This sometimes may not be an absolute contraindication with the recent published data. I will share with you later. Something like the increase of risk of bleeding, like thrombocytopenia, prolonged INR, then you have to look carefully. But again, prolonged INR more than 1.7 probably will not thrombolize, but still within less than 1.7, we can consider to thrombolize the patients. So this is a checklist from HUKM. So there are inclusion criteria, there are exclusion criteria for contraindications. So example like inclusion criteria, if the patient is more than 18 years old, if the onset is within 4.5 hours with the NIH ranging 4 to 25, more than 25, probably you can discuss with a neurology to consider whether to thrombolize the patient. Again, as I told you before, if the MCA territory more than 1/3, then we can exclude the patient. Less than 1/3, we can put the patient for thrombolysis. Again, at the aspect score more than 7, as I shared with you in the beginning, then we can consider, you also confirm that this is not a fully established infarct. Of course, consent for treatment. Then I told you before, if the aspect score is 10, is the normal CT scan, is the fully MCA infarct, then the aspect score will be 0. So those are the level of the M1, M5, M6. Those are the area you check for hypodensity in the CT brain. So you follow by 1, then you -1, -1, -1, -1. If there is evidence of hypodensity, you -1 until the 10 area, then you get a 0. Then you confirm that this is a fully established MCA infarct. But again, something I need to share with you, the pitfall of aspect score. There are a lot of analysis, subsequent analysis on mean trial, actually they confirm that the aspect score is, and the local analysis of the CT scan is not really significantly related to the effect of alteplase. The E-class 3, the E-class 2 and the IST3 also confirm there's no interaction of aspect score also. Another meta-analysis also confirm it's not really direct, there's a linkage between the aspect score and the alteplase. So again, aspect score is just a guide. It's not something like definitely answer for you not to thrombolize or thrombolize. Just use as a guide, help you to interpret the CT scan even better. So again, the exclusion criteria CT scan, we see there's a bleeding, we exclude the patient. And if, of course, you go through the checklist by the patient exclusion criteria, something like thrombocytopenia and recent NI, etc., etc. So you go to a bit detail on the exclusion criteria. So every hospital, they have the stroke protocol. So if the patient presented with you with the stroke, so you go through the checklist of the absolute contraindication, something like myocardial infarction within the last 30 days, major surgery, major trauma, not involving the head within 14 days, etc., etc., GI or GO bleeding within the trend or within or the last 21 days. So this is the algorithm before you make a decision. So once the patient arrives in the CT scan, so you'll be seen by a physician, could be an emergency physician, could be a general physician, could be a neurologist. So the team can check the vital sign, get a short history, particularly the time onset, make sure it's not more than 4.5 hours, take a quick neurological examination by doing a quick NIH score. So the nurses or the paramedic can help to check the vital sign, oxygen saturation, temperature. If your hospital have a point of care, then you check the blood sugar, you check the INR with the point of care. Then you get 2 IV access. So you can send the lab result immediately by FBC, the electrolyte profile, and of course the coagulation profile. Of course, ECG, but those are not a must. Of course, you can consider if the patient presented with stroke mimic. Then you do a CT scan. CT scan is the most important investigation because we need to rule out bleedings. Then from that, you make a clinical decision whether to thrombolize the patient. So the history will confirm there is no, we confirm this is an ischemic stroke. Then we do a CT scan, we rule out bleeding. So we can start to give the bolus in the CT scan to save the time, to cut down the door to need the time. So again, I told you, this is not a must. This is sometimes we can helpful for us to rule out stroke mid-mid. So this is another pathway that we can see. So if the patient presented with you with the CT scan, you check the CT scan. If the aspect score is more than 7 with the hypodensity less than 1/3 of MCA territory, then you check the time onset. If the time of stay is more than 4.5 hours, then you know definitely you can rule out for the patient for thrombolysis. And you can start the patient if the patient is a minor stroke with the NIH score less than 3, or the patient is just a TIA patient with the ABCD2 score more than 4, then can you consider dual antiplatelet therapy. If not, then you can start the patient on single antiplatelet therapy. So if you're able to do a CTA in your hospital, you're able to interpret, confirm this is a large vessel occlusion, which is internal carotid artery occlusion or M1 occlusion, M1 MCA occlusion, then you can carry out a CT perfusion scan or MRI, DWI to look for penumbra. So which is within 24 hours, let's say the patient has still have a very huge penumbra to go in, then you can subject the patient for thrombectomy. If the patient less than 4.5 hours, of course, you can start the thrombolysis, but again, NIH score less than 4, you can consider this, but again, this is not a absolute thing. If the patient, we have to define whether this is a functional neurological deficit or not. For example, there's a painter or artist that used to draw, then the patient has some finger numbness with 2 fingers with a very low NIH score. Even though for that kind of patient, sometimes we may consider thrombolysis. So less than 4.5 hours in the general criteria with the NIHS 4 to 24, then there's no exclusion criteria. We can start the patient with RTPA. If the NIHS more than 25, you can consider to consult a neurology to determine whether the patient should go for thrombolysis or not. Again, you can confirm by doing a CTA, there's a LVO, then you can subject the patient for thrombectomy. So again, CT scan with the aspect score less than 5, if there is a established of a hypodensity more than 1/3 of the MCA territory, then you exclude the patient for thrombolysis. So this is a chart, the algorithm for the acute stroke pathway is the commonly practiced in most of the acute stroke ready hospital. So again, my topic, I should answer another question. How do you achieve a faster door to needle time? So this is a very famous, very landmark trial published by Prof. Ahti Meri from Finland. So he come up with this Helsinki model in the Helsinki hospital, a place in Finland. He able to reduce door to needle time to 20 minutes. This is one of the something like a very short time. Most of the door to needle is ranging about 50 to 60 minutes. However, with this model, he able to achieve within 20 minutes door to needle time. He also able to transfer this model to Melbourne in Australia or replicate this model in Melbourne. So it confirmed that this model is able to replicate in anywhere. So what is the strategy? So basically the strategy or the concept is quite simple. Before arrival to the hospital, do as much as possible. Once you arrive to the hospital, to do as little as possible. So there are multiple concurrent strategies